Hello, this will be your discussion on the disorders of the adrenal gland. Specifically, we will be talking here about the decrease of your adrenal hormones and then the increase of your adrenal hormones. But prior to that, let's discuss the anatomy and physiology of your adrenal gland. So class, when I talk about your adrenal gland, these are the two glands that can be found above your kidneys. In each of these glands, there are two major parts that function independently from one another. So you have your adrenal medulla, and then you also have your adrenal cortex. So your adrenal medulla could be found at the center of the adrenal gland, whereas the outer surface is referred to as your adrenal cortex. Now, so your adrenal medulla produces what we refer to as your catecholamines. On the other hand, your adrenal cortex releases your steroid hormones. So try to remember that your medulla would release your catecholamines and then your cortex would release your steroid hormones. Let's try to go through this one by one. Now, your adrenal cortex, as I have mentioned, would release your steroids. So class, your adrenal cortex is controlled by your hypothalamic pituitary adrenal axis. In other words, it works with negative feedback mechanism just like the previous hormones that we have discussed. Okay, just like the way your TRH, TSH, T3, and T4 would work in your thyroid problems, okay, or your thyroid gland. Now, in this case, it will be your hypothalamus that would release your CRH. Your CRH is your corticotropin releasing hormone. Then, once your CRH is released, it would trigger the pituitary gland to release your ACTH. Your ACTH, on the other hand, will be the one to stimulate your adrenal cortex. And your adrenal cortex would release its steroid hormones. One example of the hormones under your adrenal cortex is your glucocorticoid hormone, okay, also referred to as your cortisol. Or a specific type, of a glucocorticoid hormone would be your cortisol. Now, why did I mention cortisol? Later on, you will see that there are a lot of hormones under your adrenal cortex or produced by your adrenal cortex. However, it is the increased levels of your cortisol that would decrease the release of your CRH from the hypothalamus. So again, it works just like your negative feedback mechanism. Okay, once the cortisol or the glucocorticoid hormones are already increased, your hypothalamus will be informed that they are already increased and your hypothalamus would stop producing your CRH already. Okay, so these are the hormones of your adrenal cortex. So you have your glucocorticoids, mineralocorticoids, and then your sex hormones. So class, your glucocorticoids, as the term implies, gluco, okay, glucose. This talks about sugar control, okay, such as your cortisol, meaning an increase on the amount of your glucocorticoids would trigger the body to have more glucose, okay, or to utilize the glucose inside our body. Then you have your mineralocorticoids. Under your mineralocorticoids, you have your aldosterone. So when I talk about aldosterone, you should be reminded again that aldosterone functions on sodium and water retention. Okay, sodium and water retention. That's why mineralo talks about sodium. Then you have your sex hormones. Okay, so your sex hormone, particularly what we're talking about here, is your androgen. So recall that your androgen is your male sex hormone. Okay, now I wrote here the 3S because the 3S would remind us of the three hormones being released by your adrenal cortex. You have your sugar, salt, and sex. Sugar for your glucocorticoid, salt for your mineralocorticoid, and then your sex for the sex hormones. Okay, so these 3S are affected again by the product produced by your adrenal cortex. So remember, cortex, steroids, CS, and then the 3S. So sugar, salt, and sex. Now, let's talk about the sugar, glucocorticoids. One of the effects of your glucocorticoid is to increase the CBG of your patient, to increase the capillary blood glucose or blood sugar levels of your patient. Okay? Then, take note that in this category of steroids, this is where your corticosteroids would belong. Okay? When I'm talking here about corticosteroids, what I'm referring to are the pharmacologic corticosteroids. So these are considered to be exogenous corticosteroids. When I say exogenous, it is outside of the body. Okay? It came from outside of the body. So recall that your corticosteroids are given to decrease the inflammatory process. Okay, so the same function class is being done by your endogenous glucocorticoids. So when I say endogenous glucocorticoids, that is the glucocorticoids which is produced inside our body. Now, the side effects of your exogenous corticosteroids would involve your diabetes mellitus, you have your osteoporosis, and even your peptic ulcer disease. So class, the same thing would happen if there is hyperperfusion or hyperexcretion of your glucocorticoids inside your body. Your patient would manifest with diabetes-like symptoms such as the increase of your blood sugar. It would make the bone brittle because it increases the osteoclastic activity, and that it would increase your risk for ulcer. Now, if there is large exogenous corticosteroids, in other words, class, there are a lot of steroids being administered to the patient. Okay, I'm talking here about pharmacology. There would be a decrease of ACTH. Okay, your ACTH would think that, oops, there are already a lot of steroids in the body. So your CRH, ACTH would be decreased. And later on, that would result to the decrease of your endogenous glucocorticoids. In other words, the glucocorticoids produced by your body is decreasing because it perceives that there are a lot of artificial or exogenous glucocorticoids for that matter. Now, the adrenal cortex would atrophy because the adrenal cortex will not be doing anything. Okay, the adrenal cortex perceives that there is enough glucocorticoids in the body. Okay, now, common steroids that we give to our patient. You have your prednisone, you have your hydrocortisone, you have your dexamethasone, so on. Now, once this glucocorticoid would be suddenly discontinued, it would result to adrenal insufficiency. Okay? That's why we always repeat in pharmacology that whenever your patient is on prednisone, whenever that your patient is on steroids, we taper the doses gradually. We cannot just stop it abruptly, because by the time that you stop it abruptly, your adrenal cortex will be in shock that there is already lacking steroid levels inside the body. Okay, because for that period of time, your adrenal cortex has been accustomed that there is an exogenous source of your steroids. So again, to prevent your sudden adrenal insufficiency, when I talk about administration of steroids, you need to taper the medication. Then, mineralocorticoids. So your mineralocorticoid is primarily concerned with your electrolyte control, okay, electrolyte balance. So one example of your mineralocorticoid is your aldosterone. So class, your aldosterone, again, I would like to repeat, your aldosterone talks about sodium and water retention. Now, because of sodium retention, one problem that you would have is, of course, hypernatremia. And then next to hypernatremia, you would have your hypokalemia. Because remember, sodium and potassium does not go together hand in hand. They are both positively charged, hence they tend to compete. Okay, so class, if there is an excess of your mineralocorticoids, you will have problem with hypernatremia. Okay, sodium problems would manifest with neurologic imbalance. And then you would have problem with your potassium. There will be a decrease in your potassium levels. And problems with potassium would manifest with your cardiac problems. Then we have your adrenal sex hormones. So when I talk about adrenal sex hormones, this would be the release of your androgen and some amount of estrogen. So if there is an increase of your adrenal sex hormones, okay, among women, that would result to masculinization. In other words, class, your female patient would have the male sex characteristics. They would grow beard, their muscles will become bigger. Okay? Whereas on men, there will be feminization. And then in children, there could be premature sexual development. Okay? And this is what we refer to as your adrenogenital syndrome. Adreno, your adrenal gland affecting the genital system. Okay? So you have your adrenogenital syndrome for that matter. Now, adrenal medulla. Okay, recall earlier that your adrenal medulla would release your catecholamines. So what are these catecholamines? Your catecholamines would act directly on your autonomic nervous system. Okay, so your catecholamines, examples of which are your epinephrine and your norepinephrine. Now think epinephrine and norepinephrine. Okay, they are the ones for your sympathetic nervous system, hence your fight or your flight response. Okay, their effects would be it would ensure catabolism of your stored fuels, which would supply for the caloric needs of the body. As I've mentioned, it is for fight or flight response. It would lead to the release of your free fatty acids. It would also increase the basal metabolic rate and the capillary blood sugar or the blood glucose levels for that matter. Okay? Now, I hope that you are familiar with those hormones that I've been talking about. So again, when I talk about the medulla, it releases your catecholamines. And examples of your catecholamines are epinephrine and norepinephrine, which are important for sympathetic response. And then under your adrenal cortex, it would produce steroids. And the three steroid hormone that we are talking about is sugar, that would be your glucocorticoid, salt, mineralocorticoid, and then you have your sex, which are your sex hormones. Okay? With that concept, I hope that you're ready to learn your adrenal insufficiency and your Cushing syndrome. Now class, when I say adrenal insufficiency, this refers to your Addison's disease. Oftentimes, it is referred to as chronic primary adrenal insufficiency. Chronic develops prolonged period of time. Primary class because usually adrenal problems are secondary to adrenal damage itself. It's rare that you can find a hypothalamus and then a pituitary gland related adrenal insufficiency. So another name for your adrenal insufficiency is your Addison's disease. Addison's disease. Now, let's talk about the etiology. It may be idiopathic. We don't know what's the cause. It could be destruction of the adrenal cortex due to the presence of tumor. It could be tuberculosis. So class, you have your tuberculosis and your histoplasmosis as the common infection that leads to adrenal damage. Then you have your amyloidosis. So when I say class amyloidosis, it is a rare disease that occurs when an abnormal protein called your amyloid would build up in your organs and interfere with their normal function. So again, in amyloidosis, there is an abnormal protein that builds up in your organs and alter their function. Then you also have your fungal infection and hemorrhage, which can cause your adrenal insufficiency. Now, pathophysiology. Our problem here in adrenal insufficiency is that there is hypofunction of the adrenal cortex, meaning the adrenal cortex is not functioning well. With that, there will be a decrease in your SSS. Okay, there will be a decrease of your glucocorticoids, there will be a decrease of mineralocorticoids, and then your sex hormones. So what would be the effect to our patient? Okay, metabolic effect. Because of the decrease of your glucocorticoids, your patient would have hypoglycemia. Okay, remember, glucocorticoids, cortisol, we are talking here about sugar control. So your patient would have weakness and then easy exhaustion or easy fatigability. Now, because of the altered metabolism of nutrients, your gluconeogenesis during fasting may not occur. So when I say gluconeogenesis, remember this is the coping mechanism or the strategy of our body to form glucose from other substances such as your amino acids. But if your patient is having Addison's disease, gluconeogenesis might not occur because of the lack of these hormones. Okay, that would lead to the depleted glycogen store, which is later on leading to hypoglycemia. So because of the hypoglycemia that your patient is experiencing, there will be a secretion of your MSH. Okay, your MSH is your melanocyte stimulating hormone. Okay, so you have your melanocyte stimulating hormone. So class, it tends to be decrease. It tends to be increase whenever there is hypoglycemia. Then class, melanocyte. So class, when I talk about melanocyte stimulating hormone, this is important, deemed important in protecting the skin from your UV rays and the development of pigmentation and the control of appetite. So class, the secretion of MSH may be intended to increase the appetite of the patient. However, class, increase of pigmentation would mean that your patient is having also high levels of MSH. So class melanocyte, it's intended to protect your skin actually. Okay, so these are the effects of your Addison's disease in terms of metabolism of nutrients. Now, on the GI symptoms, your patient would experience anorexia, nausea, vomiting. Okay, diarrhea or constipation may be either common. Then you have your abdominal pain for this patient. Then fluid and electrolyte imbalance. So remember that we are talking here about the lack of your aldosterone. So because of the lack of aldosterone, there is an inability to preserve sodium. Okay, because of that, there will be chloride and water loss. Because remember, sodium, chloride. Okay, they work hand in hand. Now, there will also be chloride and water loss due to the lack of aldosterone. This leads later on to dehydration and weight loss. In more severe cases, you would anticipate your metabolic acidosis, and then the serum sodium would be increased. Okay, because of the increase of your serum potassium, kindly correct me, that's serum potassium, okay, that would be increased, arrhythmia would result. Okay, there you have problems with arrhythmia. Now, class, this is an example or an image illustrating hyperpigmentation in your Addison's disease. This one is your bronze discoloration in Addison's disease, which is brought about by the production of your melanocyte-stimulating hormone. Okay, still hyperpigmentation for Addison's disease. Okay, so changes in oxygenation. Class, for the changes in oxygenation, it results in the decrease of your cardiac output. Because remember, okay, you will have problems with salt, sex, and sugar. So your cardiac output later on would lead to low blood pressure. Your patient has weak pulse. Then there will be orthostatic hypotension, meaning you do not ask your patient to stand up straight, okay, to be on that position. Okay, so orthostatic hypotension. So you need to monitor that your patient will have gradual position changes. So not a sudden stand up. Then lightheadedness, dizziness, and then syncope, followed by your arrhythmias. Okay, so these are all the sequelae of your Addison's disease. Then, because of the changes in cellular growth and proliferation, there will be an alteration on the secondary sexual characteristics in women and men. So among women, there will be disturbances in menstruation. There could be absence or sparse axillary and pubic hair. And then there could be impotence, okay, because of this disorder, Addison's disease. So the disturbances here, class, in menstruation is related, of course, to the decrease of your sex hormones. Okay, decrease of your sex hormones. Then, perception and coordination is also affected. So there will be muscle weakness and fatigue. Deterioration of mental status will include drowsiness, apathy, inability to concentrate, irritability, and anxiety. So this would signal that the mental status is already deteriorating. Emotional disturbances. So your patient with Addison's disease may have your mild neurosis and then may have your severe depression. One complication of your Addison's disease that you're watching out for is your Addisonian crisis. So your Addisonian crisis is also referred to as your acute adrenal crisis. It's considered a medical emergency to the extreme degree. Okay? So class, what happens here in your adrenal crisis or your Addisonian crisis is that adrenocortical hormonal reserves are suddenly inadequate to meet the body's needs. Okay? So remember, okay, the hormonal reserves are suddenly inadequate to meet the body's basic needs. So the signs and symptoms of your acute adrenal crisis would include hypotension, rapid weak pulse, rapid respiratory rate. There will be pallor and there will be extreme weakness. Okay, so class, that is what happens in your acute Addisonian or adrenal crisis. So physical and psychological stressors, class, such as your exposure to colds, your overexertion, infection, and emotional distress, okay, should be avoided because this could trigger your Addisonian crisis. So how do we manage these patients? So class, the therapeutic management for Addison's disease would include your medications. Remember, we lack your salt, sex, and sugar. So let's talk about first your sugar. So class, hydrocortisone oral or IV could be given to the patient. So the purpose of your hydrocortisone oral and IV formation is for you to replace the glucocorticoids, okay, and your mineralocorticoids such as your florinef. Okay, so class, remember there is a decrease of sex, salt, and sugar. So we're talking here about sugar again. Next, liberal salt in the diet. This would increase the need to increase the salt intake by 5 to 8 grams per day. Okay, so class, the 5 to 8 grams per day would be already sufficient to augment for the needs of your our body. Then diet. So you have your high carbohydrate and protein diet, and then medic alert bracelet and emergency kit, especially if you're having your glucocorticoid injectables, because the paramedics would want to know if what happened. Then, for Addisonian crisis, our goal here is to rapidly administer IV fluids, okay, your glucose and electrolyte, especially sodium, and then the replacement of missing steroid hormones and vasopressors. Okay, so D5-NSS fast drip, YD5 containing class, you have a problem with glucocorticoid. Sugar is down. Your hydrocortisone and your dexamethasone will be a good substitute for your the other one. Okay, your hydrocortisone or your dexamethasone would be a compensation for your glucocorticoid decrease. Okay, plasma would be administered if your patient is dehydrated severely. Your vasopressors, on the other hand, class, is capable of having your vasoconstriction. Okay, so class, the purpose of your vasopressor is to promote peripheral vasoconstriction in such a way that the blood, okay, will be focused on more important organs. So it says here, your vasopressors are being titrated until the blood pressure would increase, okay, or for us to limit your blood pressure, okay, or attain the blood pressure that we need, because in this case, your patient is already severely hypotensive. Now, class, when I say titrate, so what do you mean by that? Class, for example, in the clinical setting, if I'm talking about norepinephrine, dopamine, and dobutamine, they are usually prepared, class, in a 100 ml bottle of fluid and then hang along with the IV fluid of the patient. Okay, so class, when I say titrated, for example, if the BP of patient is, let's say, for example, 60 palpatory, which means I can't feel 60 mmHg, however, I could not feel the diastole anymore. So class, if that's the case, the recommendation is for us to administer your vasopressors. Okay, so class, vasopressors, such as your norepinephrine, commonly known as Levophed, once class the patient is having a BP, like for example, 60 palpatory, you need to increase your vasopressors. Usually, class, we are doing this at increments of 5. Okay, and then class, it would be continuously increased until you reach the limit or until the patient's signs and symptoms would subside. Okay, try to remember that. So class, again, your vasopressors are being titrated, and then its effect on the blood vessels is to cause your vasoconstriction. Okay, the vasoconstriction again is to focus the blood flow on the more important organs of the body. Now, you have your hydrotherapy and antipyretics. Under hydrotherapy, I would like to emphasize still that your patient should have an increase in fluid intake. Then strict bed rest for recovery purposes. Antibiotic therapy is only recommended if your patient would have infection. Then, of course, we need to correct the hypoglycemia. So correction of your hypoglycemia may be done using your D50 water, okay, or simply your D50. Okay, so class, in the succeeding discussion, we'll be talking about your Cushing's disease. I hope that you have learned something from this discussion. Thank you for your attention.